Thank you very much. First, I want to say that I've learned so much in this conference. And as I've said a couple of times, you know, I see the connection between what's happening from a health perspective and probably beyond the health perspective with the LGBTQ community and what's happening, I guess, overall in regards to vulnerable communities across the state and across the country, but here in the state that my office focuses in on. I'm hearing, for one thing, I learned a new term since I've been here, sexual minorities. I never heard of passing as it relates to the LGBTQ community. That's interesting to me. I've heard about discrimination, and I've heard about people being treated differently. And when I go around the state and I speak and I participate in a variety of different meetings, it just strikes me. And as an African American male, what I think about, unfortunately, constantly, is I just want to be treated the same as you would treat other people. Just because I am an African American, don't treat me differently. I'm a man. I just want to take care of my wife and my family just like you. And when I see or hear some of the stories that I'm hearing today, I would imagine those of you that are in the LGBTQ community just want to be treated the same. I'm walking in the door, I have a cold. Don't treat me differently because I'm in a different community. So that just struck me. So with that, I do want to encourage you to kind of hang in there with us. I know that we stand between you and your evening activities. I will tell you it's got to be 90 degrees outside. So you probably want to stay in here in the coolness. You have cold water in front of you. You have a comfortable seat. So hang in there. And I would say to you also that the planning committee chose this august group. They put these folks last because they know that they have some powerful information that they want to share with you. So we're going to jump right in. We're going to try and keep this moving. I'm going to ask each of the panelists to introduce themselves. They're just going to give you their name, their organization, and how long they've been working in this space, if you will. You have their information, their more extensive bios in front of you. I'm then going to ask them a series of questions, and we will get their feedback and their response, and then we will give you all the opportunity to answer questions in the balance of time. So I'm going to start with Betty to my left, and I'll go all the way down to my right with Kat.
Good afternoon. I'm Betty Hill. I'm the Executive Director of the PERSAD Center, which you've heard about a couple of times today, but we're actually the nation's second oldest licensed counseling center serving the LGBTQ communities with offices in Pittsburgh and in Washington, PA. And I have been privileged to be their director for 16 years. I've been working at this since I was born, as I identify within the community, and was born and raised in a rural community in western Pennsylvania.
Hello, everybody. My name is Michael Brookins, and I'm from Project Silk from CHS, Community Human Services. Project Silk has been around for about 5 years now. I'm actually one of the original founding members who actually created the project with another coworker. We've been doing very, very great. I'm very proud of the project. I've been doing this since I was 13 years old. Started out with Planned Parenthood with Sue. I'm sure all of you guys know her. She's awesome. But I look forward to doing more things in the future with Project Silk and other organizations.
Hello, my name is Mary Ann Patterson. I'm here representing the Washington County Gay Straight Alliance in Washington, PA. I've been a member of the board of directors there for the past 4 years. Professionally, I am an emergency department nurse at Cannonsburg General Hospital, a community hospital in Cannonsburg, PA, part of the Allegheny Health Network. So I come at this from a couple of different avenues. Thank you.
Hello, everyone. My name is Sonny Concepcion. I work for Northwest Rural AIDS Alliance, and I'm the High Impact Prevention Coordinator. We are an organization that take care of individuals living with HIV and AIDS, and I've been working in the field of HIV for almost 20 years.
Good afternoon. My name's Kat Carrick, and today I'm actually here to represent George Washington University's LGBT Health Policy and Practice Graduate Certificate Program. I'm a core faculty member there. I helped to design the lesbian health course and the rural LGBT course. I've been an activist in Pittsburgh off and on for 14 years. I've moved away from Pittsburgh 5 times. I think it's in the water, keep coming back. But I used to also be the vice chair of the Gay and Lesbian Community Center and kept that organization going by writing grants.
Fantastic. As you see, we have a wonderful group of folks. Let's give them a round of applause in advance. Okay, the first question I have has a fair amount of background, and a lot of this you heard previously, but just as background to this question. A Healthy People 2020 report cited that the LGBT community are more likely to attempt suicide, more likely to be homeless, and have a higher risk of HIV and other STDs. The LGBT populations have the highest rates of tobacco, alcohol, and other drug use. The transgender individuals experience a high prevalence of HIV and STDs, victimization, mental health issues, as well as suicide. And again, I know you heard all this earlier. Gay and bisexual men have higher chances of major depression, bipolar disorder, and anxiety disorder compared to other men. There is much that rural providers can do to ease their burden and improve the experience and care provided in their offices and community settings. So the question is, what has your agency done to increase access and improve experience? And I'm going to start with Kat.
Well, not necessarily an agency, but GWU has crafted a program that specifically trains healthcare providers. I have my credentials of milking cows. I milked 72 cows a day when I was in high school. I learned to drive on a tractor, so I've always been kind of straddling the worlds. I go between rural communities and more urban settings. And one of the things that has always frustrated me is that we get in conferences like this, and we talk to professionals, and we go to other conferences, and we talk to professionals, and we all agree that things have to change, but it doesn't really translate. Even as an out provider, as someone who trains healthcare professionals, I've sat in the bleachers at Washington County Fairgrounds and looked around and wondered just how many people were feeling as isolated and as lonely as I was in those kind of settings. We don't do a good job about reaching out into those rural communities, and that's really been a passion of mine in terms of how you go about organizing.
And Betty?
Well, this question is focused on the issue of rural access. And since I grew up in a rural community, I've wanted PERSAD Center to be as accessible to people as possible. And not every idea that I had about that was effective. I know that will come as a surprise to anybody who's in my staff because I would never admit that. But so here's some things that I think that I've learned in this process. I don't think there's that much difference between individuals who are LGBTQ who are in rural settings and city settings in terms of the kinds of problems that we have and the kinds of health disparities that we have. What I find that is different is the ability to access resources. So I know growing up in a rural community in Pennsylvania, just having language and exposure to LGBTQ issues was fewer and further between than in a city setting, okay? So one of the important things, I think, is outreach. There has to be an outreach process in rural communities. And I think one way to do that is to identify champions. My first idea was that I was just going to set up satellite centers in every community in Pennsylvania, and then realized that that was not effective, although we do have a few, and that works well. So if you can get satellites, great. But if not, if you can outreach and you can identify champions within communities who then you can center around what they're already doing and bring services to them, I think that's important. Ted, who was up here earlier, worked with PERSET on a project that we called Community Safe Zone. And our idea was that to take services into communities and to provide, we just provided space and connected people, and then used sort of traditional community organizing strategies where we let community members decide what they needed and what they wanted, and then we brought that to them. So I think that's an important piece. You know, some of the other things I think are just the same regardless of rural and city. So whether I decide to disclose or not has to do with whether or not I have a good experience or bad experience. Whether or not you have policies and forms that invite me to tell you who I am or whether you don't, and whether or not the people that I see have a competency. So the other strategy that we've used is simply to take training and competency, so we can do a competency assessment for an organization and then help them to build their cultural competence, as well as to provide ongoing training and support. So where we can't be, we can partner with you to bring services there and or to help you to develop your competencies and information about that.
Fantastic. Any of the other panelists want to chime in on that question?
Well, with Project Silk, one of the strategies that we use is that we have what we call a Youth Advisory Board, the YAB, where we have individuals from the community, peer LGBT youth, on this panel to discuss these things and these disparities. And we allow them to connect to and set a tone, a positive tone with the people out in the community so we confront these things. And one thing that we've learned is that we can't have fear to talk about these things. We have to confront these things head on and set a positive tone and make everything open. That way people will be willing to confront their conflicts.
So getting youth involved, fantastic. Question number 2. Rural providers have a unique opportunity to connect with patients, as they may already share bonds with individuals in other close-knit areas of rural life. What projects or services have you provided that utilize some of the unique characteristics of rural practice? And I'm going to go to Sonny for this one.
Like I mentioned before, I work for the Northwest Rural AIDS Alliance, and we're an organization that we provide HIV services to individuals that live in a rural area. We have 9 mobile clinics, and you probably be looking and thinking, you in a rural area, because I don't look like the rural people that might live in that area. But I had the opportunity to be able to serve them, because when we have individuals that have HIV and they come to our clinic, sometimes their partners come with them. And because their partner come with them at that time, I'll be able to the high impact prevention program that I work, have a conversation in which one of the first things that Sanders said, it was that treat people the way that you want to be treated. And that's my philosophy when I talk to anybody. I let them know that we're not there to judge them. And my organization has given me the opportunity to embrace them in a way that we start asking them, what would you need? What are the things that we can do to help you to identify some of the issues that you're having? And the major one that we engage with them is to be empowered to know and to be able to talk to other people about the issues like he mentioned, not to be shy about the different things that you have to say. And we're creating in our agencies in different areas what we call them a safe space. Not that we want to isolate them, but we want to have a space in where they be able to come, they'll be able to talk, they'll be able to discuss, and we'll be able to empower them to learn some things that they need to do in order for them to be able to, per se, defend themselves. be able to stand up and not take a no for an answer when we know that if it was somebody else differently, they would not tell a no. And as an agency, we have that. The most important thing is the relationship and the trust. And because we've been serving the community for so many years, they feel they're confident to be able to come and talk to us, especially me, because I'm the person that work with them in the community. And even though that I'm not from that community, I'm a person that might encounter the same challenge by being discriminated by somebody because of the way that I look. And I know my English don't sound as pretty as your English sound, but it's some issues that we encounter. We talk about like you are joking and laughing, but then we understand that there's some other things that I might be able to help them to teach them. This is what you need to do to empower and learn some things. And that's what we do in our organization. Because of the connection that we have with the mobile clinic, they'll be able to come because sometimes they come for testing, they come to get condoms or anything like that, and we'll be able to embrace them at that time.
Thank you, Sonny. Anyone else on the panel want to chime in on that one? Okay, if not, we will go to the next question, which really revolves around communication. Training and dialogues between local LGBTQ populations and healthcare staff are great ways to improve the care provided. The question is, I'm asking for examples of the services that your agency provides and how you have encouraged dialogue and training between the LGBT community populations and professional staff. And that one's targeted towards Marianne.
So with the Washington County Gay Straight Alliance, we identified a need to develop a training program for first responders, specifically focused on care provided for transgender patients. As an emergency department nurse who's married to a paramedic, I'm well aware of the need for this type of training in our community. Recently, a survey was done by Emmett Patterson, who happens to be my son, for his LGBT health policy and practice program at George Washington University. In this survey, he surveyed 46 respondents that were a mix of emergency medical service, paramedics, EMTs, and emergency department staff in the Washington County area. And if you can just bear with me with a couple statistics, there were 46 respondents that were a mix of both people. And the survey assessed their reaction to a short story about a paramedic providing care for a transgender patient. So just some couple background things. The respondents who answered the questions have worked in emergency medicine for an average of 13 years, ranging from less than 1 year to more than 40 years of experience in emergency medicine. 67% had never received training on cultural issues. 85% had not received training in LGBTQ specific health issues. However, from a qualitative standpoint, 3 themes emerged. There was a desire for training on cultural issues. As my husband said, he is a paramedic, and the group people that he worked with answered the surveys, and he said it has definitely started the conversation that the healthcare professionals desire training. We heard people speak a few minutes ago about experiences that they had that, as a healthcare provider, make me shudder that people have had this happen. But again, I don't think anybody wants to do it intentionally. It's just because we have not been trained. The respondents also fear doing the wrong thing due to lack of knowledge, specifically about trans patient issues. And finally, there was definitely a desire for training. So we are very fortunate to have Dr. Kyle Duff as a member of our health committee at the Washington Gay Straight Alliance. Dr. Duff is a family practice resident with the Washington Health System and has been working with us on our training program. Once it has been completed, which we are getting close to that point, we are certainly going to forward it to the proper people that will give it some credit so that first responders who come to our training will get CEUs and will be inclined to learn everything. Dr. Duff has also been surveying providers and patients of the Washington Health System regarding LGBTQ health care. And this continues to be a work in progress. So we've started this, we've been working on it for a while. We also have come to the conclusion, and that's verified by what I heard here earlier, that there is a need to take this beyond EMS providers into the hospitals. Emergency departments are very much in the same situation because we don't have the information that a primary care provider would have. When you go to a doctor, you fill out forms. There's a history. In emergency medicine, you treat the patient as they present in front of you, and it's how do you go through and treat everyone respectfully and do the right thing for them. So once we have this in place, hopefully next year we'll have some very different information to share with you. Thank you.
Fantastic. Thank you very much. Anyone else want to chime in on that particular question?
I wanted to say a couple things about that too. PERSAD, part of our work is that we do an awful lot of training on LGBTQ issues. And historically, what we did was we worked with individual practitioners to help them develop their competence. And several years ago, we decided to change our focus to work with systems. Because one of the things that I would caution us on is you can have an LGBTQ training in, but if that is a voluntary training that only the people who really already like the gays come to, then what, they feel good because the company's done it, but it is a choir experience, if you know what I mean. So one of the things that's really important, if you want to do this work and serve the populations, is that you do across the system, not just your direct care providers, and I think our consumer panelists talked about, sometimes the negative experiences are with the billing department or the person who schedules. So it really does need to be an across-the-boards kind of process in order to really be effective. And one of the things that I would suggest also is that you think about this as a relationship over time with somebody who is helping build competency in your organization and with the community, that it isn't a one and done. So some possible opportunities are, we have a training that we do that's called Creating Welcoming Environments. So we have kind of a top 10 list of things that you can do to make your organization or your system better and more responsive to LGBT communities. So that's one thing. A cultural competency assessment. So we can come in and spend a day with you and talk with your leadership and look at policies and procedures and actually give you a score as to how well you're doing on what would be best practices in working with this community, and give you a set of here's where you're doing outstanding and here are some opportunities for change, and then we can help and assist you to bring those things up to speed. One other thing I would say is one just immediate test that you can do is if you're thinking about how well are we doing with LGBTQ communities, if you look at the total number of people that you serve, do you have an identified population of LGBTQ people that's somewhere between 5 and 11%? If you don't know your 5 to 11% of LGBTQ people, then either they're not coming to you or they're coming and they're not telling you. So that can be an outcomes piece that you can look at.
Thank you very much.
I just want to make a comment on regard of the training the staff. And the work that I do, because we educate the patients that have HIV as their partner to encourage them to get PrEP, a lot of times they go back to their primary doctor and talk about PrEP. The doctor don't even know what PrEP is, or they don't want to treat them because who they are. And that opened the opportunity for our agency, myself, to be able to come to that primary care office and educate them, because a lot of times, most of the time we think the people know, but they don't know. We have to educate them. We have to let them know. And at that time, I'll be able to talk to them about the different individuals that we work with in order for them to be able to know when we send somebody, it might be for the LGBT community plus, and you be able to be more receptive to what they need, because it's something you don't need to judge them. You just have to learn more about the needs that they have in order for you to be able to serve them better. And that gives us an opportunity to embrace the community and educate those that serve that community, because they don't always know what we think they know.
Thank you, Sonny. This next question, actually the background, I think is going to really speak to some of the things that Atticus was discussing in the previous panel, It's up to the providers to start the conversations, and open-ended questions and non-judgmental tone are powerful tools. The responsibility of disclosing behavior and identity should not fall onto the patient, but rather become a vital piece of information, no different than blood pressure, temperature, or heart rate. Unfortunately, recording this vital piece of information isn't always easy. Electronic health records don't always include fields on sexual orientation and gender. But it's not enough to just ask a behavioral question such as, are you having sex with men, women, or both? Providers should know how to respond when a patient replies both. So the question is, could you give insight, I'm going to pick on Betty for this one, could you give insight into how providers can start welcoming conversations and respond to disclosure from patients?
Well, certainly the welcoming conversations is a really important question. I'm going to back up a second to talk about forms first. So even before the conversation, very often in spaces we're filling out forms. And I think a point was made, and Ted emphasized it then too. If I'm filling out a form and the form does not include me, I already am backing up here because I already don't feel like you expected me to be here or that you are really ready or want to treat me. So, and those kinds of forms are usually in relationship to gender questions, can be exclusive, sexual orientation questions can be exclusive, and I want to add also relational questions can be exclusive. So sometimes I use the example, if you ask me about my relationship status and you ask me if I'm single, married, divorced, or widowed, I'm stumped, right? And so we have to do a better job of providing boxes that are inclusive of everybody that's coming. And that's a starting point, because I've done my clipboard and I've turned it in, and I'm already either ready and feel like you wanted me to come, or I'm a little bit closed off because I already am not sure. And I'm going to make some of my decisions about whether or not I did disclose to you based on whether or not I think you are ready for my answer. So I would start this with an issue of forms. And then the other thing is, you know, all of us come to working within LGBTQ issues with varying levels of experiences, okay? So some of us have had lots of opportunity to have exposure, or exposure, both, really, depending on your, well, that's another training. But we've had varying levels of exposure. So some people have had lots of opportunities to interact and work with LGBTQ people, so they use the terms, they use the words, they can converse comfortably. So the first thing is, if you don't have those experiences, it's not a bad thing. You know, we're all experienced and inexperienced in lots of different ways of difference. But you have to practice. You have to find some friends. You have to talk about this stuff, because you don't want the first time that you use the word a little lesbian for it to come out like that, right? You have to have used the terms a little bit more frequently. So comfort level first. And if you're not comfortable, you don't ask. That's what we know. We know that practitioners who are not comfortable, even if it's available, even if it's the practice, will avoid asking. So we have to find ways to practice this in our teams and before we're in front of a patient. Then it's a matter of bias and attitude, right? So I can know the words, but if I have an attitude, and an attitude is a readiness to respond in a certain way. If I have an attitude, my asking, I can use the same words, but what comes across will be very, very different. So we have to work on our own biases. So one of the first questions is, when somebody responds both to that question, you need to know ahead of time, when somebody says both, how do you feel about that? What do you really think about that? And deal with your attitude about it first. If you don't have a negative reaction or attitude, that will come across. And the next questions, even if you stumble a little bit, if you are coming at it in an open-hearted way, you'll have a lot more grace and a lot more ability to ask the follow-up questions. I'll stop there.
Thank you very much. Before I go to Sunny, what do I hear there? Did you want to clap again? Okay. Wow. She really liked that response. I'm gonna ask you to indulge me a little bit. Would all you folks just stand up and just give a quick? Consider this halftime, even though we're past halftime of this session. But if you wouldn't mind standing up and just giving a quick little stretch. Thank you very much. There you go. Hope that helps.
We're gonna do downward dog.
We won't even go that far. You can take your seats. Before I go to Sunny, let me just, I guess, put something out there. I'm hoping that there are, Betty, I'm kind of directing this one towards you, that there are template forms. I figured there would be, that we could make available to folks so that they don't have to come up with and create an appropriate form, but that there's a form already available that has the right questions to ask and that type of thing.
Yeah, I think there's lots of great examples out available. If you can't find them, we can direct them to you. And if you want somebody to look over your forms, to just say, how does this look? What's missing? Are these the right responses? We're happy to help you with that as well.
Fantastic. And I guess something else I'm going to put out there, and you could hold us accountable, but I'm going to give myself somewhat of a leeway in regards to time. Our Office of Health Equity has a landing page. I was about to call it a website. It's not a website. It's off of the Department of Health's website, and we have a landing page. And I have some, okay information up there. I'm always looking for more, but my problem is I don't know anything about putting information up there. I always count on my interns to do so. And I now have one intern. I'm about to get another one. So before the summer is out, I will have a revised Office of Health Equity page. And I would extend an invitation to all of you that could provide information to me, that I would place that information, resources, I don't know what I'll call it. Right now I'm just going to call it the LGBTQ resource page, because I can't come up with anything sexier than that. But if I can get that information from you, and we'll figure out maybe a way to formalize this, but if I can get that information from you, I'll put it up on our website, and I don't know how many people look at it, but hopefully people will look at it. So, Sunny, going back to you on that same question, if you would give some insight into how providers can start welcoming conversations and respond to disclosure from patients.
It usually be when they encounter sometimes the patients that we send there, even though they have the form, they have to be trained to how they use the form. That way, when they answer those questions, they don't treat them in any kind of way and say things, oh, I didn't know that you was a bisexual, or I didn't know you was a lesbian. And they'll be able to accept whatever you put in that form. That's why one of the jobs that I do is just train the provider first in the language. They need to understand the language. They need to understand what they're going to come and the things that they're going to say, and have a little bit more cultural competency in which they're going to do in order to be able to receive the services. Because for a long time, the LGBT community, it was not something that it was in the front that everybody would talk about. It was a secret, and most people had to hide their identity because the way you was treated. Now that things are different and changing, we have to be proactive to be able to help them to move along with the learning curve in order for them to be able to provide the services that they need. Sometimes I have an office that is not in Erie, it's in Lawrence County, and they are really eager to know more because they want to serve the population, but they didn't know where to do. They didn't know where to go. And because of the prep that we offered to somebody, I was able to call. They call me, and I give them information, and they ask me, can you come? And when I came, they want to learn, but they didn't know how to go about to learn because they didn't want to offend anybody. And that's basically how I do it.
Fantastic. Something comes to mind. I'll go to you in a second, Kat. Something comes to my mind, I guess I wanted to mention from earlier. I went to a conference maybe about a year ago, and I heard about cultural ambassadors. So there's, just say, in this case it was, an African-American doctor serving patients in Appalachia. Well, chances are the African-American doctor doesn't know much about the culture of Appalachia. This gentleman was not from Appalachia. But he had someone that was from that community, knew about the culture of that community, and in fact was a cultural ambassador. So not just say like a translator from the Latino community, but someone that really knows that culture. I wonder if that's not something that we could look at for the LGBTQ community. And Kat.
I was just going to say, don't be afraid to make mistakes. If your heart is actually compassionate for the LGBT community, if you're coming from places that don't have any services, I'm a graduate of Pitt Social Work School, and we used to have the, once a year, the Pride Parade would come around, they'd put a table out and everything be all LGBT friendly. But when we actually got down to the nitty-gritty of it and started looking at curriculum, only 2 classes had any content at all in terms of required reading or films or any sort of academic materials to back it up. A shout out to Paula Davis, because she was the instrumental person to start getting Pitt Med School diversity training inclusive of LGBT. I was on the very first panel that they used there. It was 15 minutes, ask the queer anything. Hi, I'm the lesbian, you can ask me anything, and that still goes true. You guys can ask me anything. But it was really kind of good intentions, but fell short, right? Because they had a lesbian, a gay man, a bisexual, and a transgender person. Guess who got all the questions? Right? The next year we got a little more. We got 15 minutes plus 15 more minutes. The next year it was a whole hour. Then it started to become a whole day. So change can be incremental, and we can learn from our mistakes, okay? The other piece is required training, because every single time you're going to have somebody who will roll their eyes, who thinks this is a waste of time, that they've heard all this stuff before. I've been doing this for 33 years, and I still learn something every single time at a different conference.
Thank you very much, Kat. Next. Oh, go ahead.
I'll be really, really quick. Also, building rapport with your client is very important, because when a client comes into your office, say for an HIV test, you don't just jump right into, we're going to get started with this HIV test. I like to soften the blow and get to know them at first, see where they're from, make a connection with them. That way, when it comes to filling out the forms, it's about terminology to me too. Understanding how the client is talking to you and the terms that the client's using. That way, when you start filling out the form, you can identify how the client identifies.
Thank you, Mike. Next question, a little background first. While lesbian, gay, bisexual, or transgender individuals differ in their needs, these populations commonly suffer from healthcare disparities, as we've heard earlier, stemming from systematic social disadvantages. I guess one phrasing I have not heard too much of here is social determinants of health. Kind of speaks to that. We commonly group LGBTQIA together, but each population has many different populations within each representation. So it's difficult to do sweeping generalization. And this is a question that I'd love to get several responses from off our panel. And the question is, how does your agency respond to distinct needs of individuals? So I think I'm gonna go from left to right. Let me start with Betty.
I wasn't expecting that. Okay. Well, I think the question is exactly right. We do lump LGBTQ plus all together, and putting it all together has really been about social justice and history and about a shared experience of discrimination. So that's all about, so if you're starting out just getting rid of the biases and reactions fits everybody. But I think when we get down to healthcare responses and services, then we have to get a little bit more nuanced and begin separating out the letters. And just as we went over the health survey, we need to recognize that different issues affect different letters differently. So what we want to do is to create responses for those letters that have the biggest problems. That's how we do it. We look at where are the biggest issues and problems, who's suffering the most from this particular issue, and then how do we address that population specifically.
Okay, so Project Silk, what we do is we literally bunch them all together. Again, we have what we call the Youth Advisory Board. We have each individual represents each letter, LGBTQIA. And we form a meeting, and they come in once a month to discuss any type of issues in the community. We get all of their inputs. Actually, they pretty much run this space because the space is theirs. So what we do is we give them all a voice and give them the opportunity to all speak.
Thanks.
So one of the things we do in the Washington County Gay Straight Alliance, we actually, compared to some of the other people here, don't have actually direct healthcare service on site. But we certainly, provide resources for people. Probably one of the best things we do is we have a monthly potluck dinner, at which point, people come, and that's a time when people can talk and, talk with each other, and they can, get that information about what doctor do you see and how do they treat you and how is their office staff. I already talked about the program to train people with regards to providing care to transgender people. We have a resource list for, family members of, again, specifically trans people. So, if someone calls and says, I have a 10-year-old who's telling me they're transgender, and, there is value in talking to a parent who has gone through the same thing and, knowing that you're not alone. So we try, again, to coordinate, people to the right resource. And PERSAD we've had a, relationship with them for some time. And so we get a lot of common, referrals back and forth there. So, and again, I think that is important to know that people can just, in a social situation, have those conversations and help with their healthcare decisions.
In our organization, I'm grateful because the first thing we do, we listen. We don't always ready to talk and tell them because a lot of time we don't know what they're talking about, but we listen and we deal with individuals. And then after we deal with the individuals, we ask them if you want to group this to be able to help other individuals. And that's how we utilize and try to help the community that we serve, because we want to listen to what you need and then be able to find the resources to help you to understand the issues, how to address the issue, and how to go about it. It's not just sit down, let me tell you, this is how you're supposed to do it. The most important thing is to listen.
Since I'm no longer with particularly a service organization, but more toward higher education, I think that my understanding is that we need to have the most vulnerable represented. The people that are homeless, the people who are in rural communities, the people who are handicapped, the people who identify in multiple layers of oppression are going to be the least likely to come knocking on the doors. And we've got to think in terms of how do you do outreach for those kind of folks? How do you advertise? The last time I left Pittsburgh, I moved to Arkansas.
Wow.
Within a year, I knew 2,000 people who identified as part of the community. People who had grown up and lived there their whole life didn't know that many people. And I didn't do it by putting pride parades out there or putting out flags on my lawn. I would tell two people, say, bring friends, start having barbecues in the backyard. I always got calls from folks that say, are you going to have flags out there? Are people going to know that I'm coming there? I'm like, I've got a 6-foot privacy fence and a pit bull. That's safety. Everybody can do a potluck, right? Those kind of organizing can work in rural communities. If you become known as a safe person, then before you know it, you've got that ambassador into that community.
Thank you very much. Mike, this question is specifically for you, and I think it's right up your alley given the population that you serve. And the question is, given the health risks experienced by LGBT people, how does your agency help clients address and minimize these risks?
Okay, so we have our four-step process with this. First step is safety. We have a safe space to allow the kids to come and feel safe. The next thing is we build trust and rapport with the youth. Also, number 3, we identify the reasons for their coming because everybody comes for a different reason. Also, number 4, we create a non-judgmental environment. So how do we do it? We meet the client where they're at within their current situation and build rapport by taking time to know the client, which makes identifying the core issues much clearer. So we identify the issues from the approach, the barriers, set goals, create the steps to meeting the goals. Also, when it comes to creating the positive atmosphere, we form small group talks where youth can openly discuss stigma, community issues, or whatever they decide to talk about at the time. And these group talks consist of the facilitators are a mental health specialist, a peer navigator / staff, and also a consumer from the community. Which this allows us to discuss the risk openly without them being afraid to discuss it. Because a lot of times, youth don't want to discuss these things because they're being judged. Because a lot of people come to our space from off the streets from prostituting or escorting or doing drugs and things like that, and they really want to talk to people about this and also find people that are just like them where they can share stories like this. And we create an environment, an atmosphere where people of alike can talk about these things without being judged upon it. Also giving options and not directives and telling these people what they have to do. We let them answer their questions and find their own options for themselves.
Thank you. Anyone else want to chime in on that particular question? If not, believe it or not, this is actually my last question that I have, and then it's your turn. Rural communities have many layers of social stigma to navigate. In some cases, outreach with rainbow flags or easily identified logos might do more harm than good. So the question is, how can agencies help foster grassroots events to provide a safe place, a safe space for questions and discussions not usually acceptable in small rural towns or church congregations? I'm going to go to Kat initially on this, but anyone can chime in after her.
Well, this is definitely a passion. Knowing that there's different risk levels depending on the vulnerability or the privilege that people have, that the stigma increases. So I'm going to tell you a little bit of a story of one kid that I worked with. I was the Gay Straight Alliance advisor for Arkansas State University. And in meeting Jamal, he talked about the fact that he was Christian. So when he went to church, he couldn't talk about being gay. He was black, so he could get support from his family when he was called racist names, but he couldn't necessarily feel comfortable walking into a gay space if he was the only black kid in that gay space. The fact that he identified as gay from a very young age on, and yet still wasn't comfortable talking to people about what that meant to him, and that how can you be gay if you haven't had sex with a man? Because he was 22 and still a virgin. And so living in a rural community, how do you find your network? How do you find your tribe of people who you feel safe with? Plus he was handicapped, he had MS, right? And so when you put all that together, when he did come out to his grandmother, she kicked him out, so he was homeless. Multiple layers of oppression means that you have to bridge between all those different layers. You have to be able to have access and ambassadors on many different levels. He came into my life because he was one of the kids that got referred to me by another kid in the GSA saying he doesn't have any place else to go. I've taken in over 20 kids in the past 10 years. I always have a spare bed, and even though it can be a major damper in my own life, I believe in having a roof and 3 squares a day makes somebody be able to have that practical support to get them on their feet again. That stigma is something that we talk about in these kind of rooms, but we don't have a lot of actual practice in putting into action. And I think what we could do is actually create a network, right? So if there's an informal network that is there to help kids like that, then we're going to have a better chance of seeing them get past those rough years to being productive adults instead of having one more statistics. I hate it when they read those stats. Don't you feel like passing out razor blades? Oh my God, all the negatives about being LGBT. You know, we got to start talking about resiliency and how we can nurture resiliency in rural communities.
Wow, thank you. Talking about going above and beyond, Kat has her own shelter, apparently. Anyone else want to chime in on that particular question?
Again, you know, in a small town, you know, you always have to be cautious and be able to provide a safe space without making yourselves a target. We have also been very, very fortunate in Washington, PA specifically, to have a relationship with the church. It's the First Presbyterian Church, 1793 in Washington, has been an open friend to the community for many, many, many years. PERSAD has had office space there for, I'm not sure how long, Betty, but it's been a long time. And people from the community have started actually coming who've, you know, not felt they've been able to go to church, have a church home regardless of, you know, what their past experience has been, and have become and are welcomed by the congregation, which is an affirming thing for us as well. And so it is possible in a small town to have that. Thank you.
We've actually been pretty lucky to collaborate with a few agencies that's in the rural areas. We're actually located in the city. We've also had a lot of youth come in from the rural areas and making them feel safe at the safe space. They go back out to the rural areas, tell their friends all about it. Plus we have video games, PS4s, food, everything that makes the kids, you know, want to come down and hang out with us. So we just pretty much like use the Youth Advisory Board, and they all have Facebooks. So we advertise on Facebook, plus we have our own Facebook page, Project Silk, so you guys can like our page and, you know, let everybody know about us. That would be great. So, yeah.
Thanks, Mike. Now we have about 8 to 9 minutes for questions. So you can make this easy, and we have our runner there, if you will. You can make this easy on us and not have it, that awkward space there. One. So we have a question here, and the gentleman in the back.
First of all, thank you. This was really great
Let's
information.
give them a round of
applause. One thing that I was thinking of that comes up a lot is that people come to a training like this and they feel really good and they have these new terms and they want to go out and try them, and then they make a mistake. And if you could talk about, like, what do they do once, you know, how do you back out of that once you make a mistake, and just make sure that you have a good relationship going forward?
I'll pick on Betty. Go ahead, Mike. Are you referring to a client or just an overall program, or?
So as providers, so like someone in the emergency department, say they misgendered someone, or so do you have advice for some of the providers here that maybe want to go out and use this new knowledge but feel a little worried about what to do if they make a mistake?
Well, we have to remember that we are all human and we all make mistakes. So when you make a mistake, You just pretty much identify and just tell yourself it's okay that you made the mistake and try to work on, figure out what mistake you made, how you made the mistake, and how you can make the mistake better. And also build that rapport with the client and let them understand, I apologize, I made that mistake, but we're going to do some things and follow some steps to make this mistake better, and it won't happen again. We'll try our best to not let it happen again.
So I guess it's the intent.
Yes.
Yes.
If the heart's in the right place. Go ahead, son.
And usually they know if the mistake was intended or it was a real mistake that they didn't know. And they'll be able to work with you. A lot of the things that I know about the community is being teaching by people that help me to understand, knowing that I'm not in the community, but because I'm an advocate and because of the work that I do, they want me to know. And they sit down with me and tell me terms and things that I never think that I was going to have to talk about that. But now that's how I get educated, because they don't want me to make the same mistake again. Making a mistake is nothing wrong. What's wrong is not to correct the mistake and learn that way you don't do it again.
Thank you. We have a gentleman back there that had a question.
Hi, thank you again to the panel for coming out here and providing us with so much great information. This question is actually specifically for Mike. You talked a lot about the Youth Advisory Board, which sounds amazing. How did you go about engaging and recruiting members for the board?
Well, when we first started creating Project Silk, there was like nothing inside of the space. So I'm from the barroom community. I don't know if a lot of people know about the barroom community, where people vogue and do runway and stuff like that. So I'm a big major leader in the barroom community. So I use that to kind of lure people from the barroom community to come to this space. And also going out to local venues, other people's parties, other organizations' parties, to do some networking. Also, we allow the youth to actually create the space themselves. They pick the color that goes on the wall, they pick the pictures that go on the wall, they pick the food, you know. So we pretty much, the people that took the initiative to actually create the space, we allow them to actually be the Youth Advisory Board.
All right, great, thank you so much.
You're welcome.
Okay, I'm going to say we have time for one more question. It has to be a good question, though. There we go. Do you want to clap first and then give it?
All right, so, okay. All right, so my Beyonce moment. But, so I have a question with respect to the rural community and the opioid epidemic. As of right now, I would say that I do life skills and I teach the youth. With that being said, it seems as if the opioid epidemic and just drug use is starting to be a lot more accepted at a younger age. 6th, 7th, and 8th grade are the ages that I work with. And when I discuss things like marijuana or alcohol, I'm confronted with, you know, let's talk about lean, or let's talk about that K2, or, you know, let's talk about, what was it, Gorilla Glue. And I'm like, wait a minute. And I guess I'm just asking you guys, are you, since you're dealing with the LGBT community, also getting some of this same acceptance and kind of like, yeah, acceptance and usage of drugs, narcotics, things of that nature? And then how are you guys talking about it? How are you guys talking about different ways to cope with all the different reasons why we should pull out those razor blades, or as you would say, Kat?
Well, for Project Silk, a lot of the youth do drugs, and that's just what it is, you know. They're coming from off the street, and that's a lot of the ways that they cope. Some of them come in smelling like Gorilla Glue, you know. And then within our group discussions, they like to talk about drugs a lot. But what we do is we just engage into it. We don't fear the conversation. When you fear the conversation, it creates a judgmental environment. So when you create a judgmental environment, they don't want to talk about it. But when you create a non-judgmental environment, you can talk about the opioids and figure out who does what, how they do it, how often they do it. That way, because you have to be prepared for when you know people come into your space and they do these things. So if someone comes and they deal with opioids, we have Narcan at our office, so that way we can keep an eye on that person without them knowing that we're keeping an eye on them, because we don't want them to feel like we're watching them, you know, to make them uncomfortable, you know.
Another way is harm reduction. And I don't know you remember, you probably won't because you're not too old to remember that, but years ago when I was growing up, and the thing was say no to drug. But the say no to drug, it didn't tell you the consequence of what you happen to you when you use drugs. What I do, because I see a lot of the LGBT community in rehab, because when I go to do HIV testing, and that's where I have the opportunity to do harm reduction, which is talk to them about if you're using or you continue to use, this is the consequence and how you can be affected by doing that. I'm not talking about why you're doing it and anything like that. You're already doing it, and you're going to probably continue doing it. But I'm going to try to help you to understand where you're going to be if you continue in that trend, rather than just judgmental, start telling them all this, because that don't help anybody. But usually that's the best way for me to communicate with them with harm reduction.
Thank you, Sonny. We're going to have to leave it there. I'm sure you had some additional questions you had, but we're going to leave it there. Thank you all very much. And was I right about the wonderful panel? So thank you all.